Morning, Chair. Your meeting is now live.
Thank you. Good morning and welcome to the Primary Care Commissioning Committee meeting. I'm Margaret Geary, lay member. I will be chairing the meeting today. We are meeting virtually in response to the limitations placed on governance by the COVID-19 pandemic. Members of the public have been invited to view this meeting via a link available from the NHS Portsmouth CCG website, and papers for the meeting are also available via this website. Today's meeting is being recorded so that in the event of a failure of technology, it can continue and will then be uploaded onto the NHS Portsmouth CCG website as soon as possible. Committee members and attendees are requested to keep their microphones on mute and only to turn them on when they are called to speak. Please use a raised hand to indicate that you wish to speak. Please can I ask everyone taking part today to confirm that they are present. We've had only 3 apologies. Helen Atkinson apologised, Dave Scarborough and Sylvia Macy will be absent from this meeting. Andy Sylvester is hoping to join us later. When I call your name, can you turn on your microphones and give your name and title? Jason Eastman.
Yeah, good morning. Jason Eastman, Associate Director of IM&T.
Mark Compton.
Morning all, Deputy Director of Transformation.
Simon Cooper.
He's late, Margaret. He's just having problems getting in.
Okay, Julia O'Mara. Dr. Nick Moore.
Hi, I'm Nick Moore, GP on Portsmouth CCG.
Jacqueline Powell.
Hello, Jackie Powell, lay member.
Terry Ross, I know, is struggling with getting access.
I am on my phone if you can hear me.
Yes, we can hear you. Thanks, Terry. Michelle Spandley.
Yeah, Michelle Spandley, Chief Finance Officer.
Dr. Claire Sieber.
Hi, Margaret. Claire Sieber, Medical Director, Wessex LMCs and GP out of area.
Joe York.
Hi, Margaret. I'm also on my phone. Hopefully you can hear me. Joe York, Deputy Chief Health and Care Portsmouth.
Thank you. Roger Batterbury.
Hello, it's Roger Batterbury, Chairperson at Healthwatch Portsmouth. Thank you, Margaret.
Joe Hans-Wenzel.
Jim Hanswenzel, Primary Care Commissioning Manager, NHS England and Improvement.
Lisa Harding. Christine Horan.
Hi, Chris Horan, Primary Care Improvement Manager.
Justina Jeffs.
Justina Jeffs, Head of Governance.
Steve McInnes.
Good morning, Steve McInnes, Primary Care Relationship Manager.
Stephen Orobio.
Hi there, Stephen Orobio, Clinical Quality Manager.
Rebecca Spandley.
Good morning, I'm Rebecca Spanley, Finance Manager.
And Lisa Stray.
Good morning, Business Services, taking minutes for today.
Okay. Thank you for that. We're going to move then to the register of interests. Does anybody have any amendments to that or any comments on that? Is there? Has anyone got any in today's business? Any?
So I need to just declare a declaration because obviously I'm a GP working in the city, so I'm kind of would have to declare a declaration. This is for most of the agenda. really. The other thing is that the declaration of interest register doesn't reflect that I actually attend this meeting, and I've asked for that to be amended already separately. We noted that at the governing board the other day, so it doesn't reflect that I actually am an attendee at this meeting or a member of the committee.
Hopefully we can now amend that and record that in the minutes. Yes. Okay. Thanks, Dr. Moore. Minutes of the last meeting. Can we just look at them for accuracy, please? Page 1, page 2, page 3, and page 4. My reading of it is there's no actions that we need to go through as a result of that meeting today. Most of those issues are on the agenda. We can then move, because Terry's struggling on the phone and trying to get properly onto the MS Teams meeting, can we move to primary care finance report and Michelle?
Thank you, Margaret. Actually, Becky's going to take us through the report. Thank you.
Lovely. Thank you both. Okay, so hopefully you've been able to read through the front sheet. I tried to make that a little bit more descriptive this time round in terms of the first finance report that's come for 2021, because previously we've confirmed full year 1920. So just a little bit of background about the financial regime currently. It's been slightly different in 2021 due to the COVID-19 pandemic. The usual procedure that would happen is that at the beginning of the financial year, the CCG will receive a 12-month allocation. And prior to this allocation being received, there would have been a detailed financial plan sort of backing that allocation. So prior to 2021, that planning process was started at the very beginning of 2020, and a draft plan was submitted. However, the final iterations of those plans were not submitted due to the pandemic, and this would have been due around March time. So going into 2021, as I say, it is slightly different this year in that the first allocations that the CCG received were for months 1 to 4 only. So we only had a part year allocation received. In month 5, we've now received a further allocation, taking us to receiving allocations up to month 6. So we still don't have the full 12-month allocation at the moment. Currently, NHS England and Improvement have now initiated a further phase of planning for 2021. So that's going on at this minute. So the CCG, alongside its system partners, are currently working on creating plans for the residual and the remainder of 2021. And these plans cover activity and performance, workforce and financial planning. And this is due to conclude this month in early October. So bringing that round to the finance report that you've received in committee papers today, it does look slightly different in that we don't have a 12-month allocation for us to create a 12-month forecast and comparison against. In terms of allocations received, as noted in the paper, as well as those initial allocations, each month we have been receiving a top-up allocation, which has covered us for both COVID-19 expenditure and other areas of overperformance. That does mean that at month 4, we are reporting a cumulative break-even position. And so the report that's in the papers this month is reflective of the month 5 position sort of on its own, as prior to that we're break-even. So as noted on the paper, the main variance that we're seeing in those primary care budgets at the moment is around the primary care integrated service. And this is because we are still awaiting our allocation for the GP Forward View Improved Access scheme. So that funding goes into part of the funding for that service. in 1920, we received that allocation as a non-recurrent allocation. And so we expected to receive that in the same way in 2021, so as an additional allocation. However, that has not yet been received. However, this is all being covered in the planning process that we're currently working through at the moment. So in terms of other variances at the moment, the delegated allocation that we received is as notified through this allocation process, so that has been sort of notified. The local commissioning scheme's budget was based on sort of a prior planned budget. And at the moment, we're not seeing too much variances in those two. So at the moment, it's really the fact that the improved access allocation hasn't yet been received. We do hope to have months 7 to 12 allocations imminently. So once they're received, this report can go back to its sort of original format. We can look at year-to-date benefits and pressures, and we can also look forward to month 12 benefits and pressures. But as I say, at the moment, we're sort of whacking month by month at the moment, so looking at in-month reporting. So that was sort of the comments I was going to make on the paper. I'm quite happy to take any comments if anyone has any.
Are there any questions, comments? No. Everybody content? We must on the month 5 position, so I'll take that as duly noted.
I can just see that Jackie's got a hand up.
Yeah, Jackie's just asking a question.
Sorry, and I
carry on.
another button. So I heard you note about the GPF improved access allocation. Are you confident that we are going to get that allocation, or is there an element of risk around that?
I think there's potentially an element of risk. However, it is being noted in our planning process that we're going through currently. So it will be notified to NHS England that that's still expected. I couldn't say, unfortunately, either way, but we can do what we can through the planning process.
Okay, thank you. And the other thing,
Go on, Jackie. Go on.
It may not necessarily be financial question, but I noticed that there's an allocation for the DES primary care networks, and I don't really know much about that DES, and I don't know if anyone could give me a little update on what that involves. If that's not appropriate for now, I can pick it up somewhere else.
That's fine. Is that under the GP forward view section on the report?
It's under delegated commissioning.
Oh, and the primary care DES, primary care network DES. Oh, okay. Yes. No. Of course. So that section we've separated that out because it is a DES. So it could sort of, it is much like the minor surgery learning disabilities, but it came in July 1920. As we all know, we're working, all practices are part of a primary care network now. And that DES works alongside those primary care networks. So within that DES, there are different sections in terms of funding streams. So there's a core network payment, a payment for extended hours, which used to be a DES in its own right, a payment for clinical director, so a contribution towards the clinical director. And at the moment, there is a PCN support payment, which is sort of in place of the investment and impact fund, which was due to kick in 2021. That is still due to kick in, but now from October. So that line sort of carries all of those financial elements of the directed enhanced service for primary care networks. The DES also does include the additional roles reimbursement scheme, but we've separated that out into a different line just above, just to show, because it's a significant area of investment this year and will continue to be over the next, I believe, 3 to 4 years. So it's just quite handy to highlight that outside of the sort of the other elements of the DES.
Brilliant. Thank you very much. That's very helpful.
That's okay. So, Michelle, did you want to say?
Yeah, only just to add to what Becky said in terms of the allocation. So the 122k variance is only for month 5. So months 1 to 4 has already been topped up. We're awaiting a month 5 top up, and we are very aware that we need to make sure that we get the month 7 to 12 allocation as we expect. So as Becky says, there is a risk. However, we are trying to highlight that we were expecting that allocation, and we've got expenditure that sits alongside that expected development.
Thank you.
You're welcome.
Sorry, I should have said at the beginning that I'm still on my iPad, so I can't see the hands up. So
That's
I didn't.
fine.
Okay.
Right.
Yeah. We'll help you out, Margaret.
Thank you very much.
Thanks.
Are there any other questions or comments on this paper? And then we are asked to note the month 5 position, so if we can just do that, thank you.
Of course.
Can we then move to 24R GP retirement update? Steve?
Yeah, thank you, Margaret. So this was for a GP from the Portsdown Group practice, wishing to take 24-hour retirement so that they can draw down some of their pension benefits and then continue back working within the practice. It's a fairly standard sort of thing that happens every so often with some GPs. We checked that they're doing the appropriate number of hours in the first month of their return, and that was the case. And so really this was a case of catching up with an action that we hadn't been aware of, hadn't come our way previously. So hence we did a chair's action. Margaret kindly agreed this so we could catch up with our paperwork on this, and it's all been agreed.
Okay. Any comments or questions? No hands up. Thank you. Okay, so we can just note that. Can I then move to Hampshire Isle of Wight Digital Primary Care Roadmap update? Jason? Jason on?
Sorry. Morning, Margaret. Thank you. I'm just going to give you a quick overview of the Howie roadmap and the rationale behind it, and then Chris is going to give us an update of what's happening locally across the city, if that's okay. Okay, so we've been working on developing a digital-first primary care roadmap since the new calendar year. And why do we need it? Well, it's actually a requirement of the ISCS or STP to produce a digital first plan for 4 years in order to access funding, etc. There's some national and regional defined core products that we have to look at. All the big ticket items such as online consultations we already have. And we are currently almost at the end of that 3-year contract. So this is about looking and testing the market to see what's out there, if anything else is improved or different, because we do know there are other solutions out there now. So that's focusing on that, and that will incorporate video consultations. Another interesting aspect which regionally we're looking at is trying to rationalise the telephony across primary care. So that's a very new piece of work that hasn't really kicked off yet, but will be starting very soon. And also GP Connect, which we currently use, particularly with the work Mark Compton's doing with the 111 booking, etc. And EPS, electronic prescription phase 4, which we've already implemented across the city. In terms of the roadmap, how it was developed, there's been lots of stakeholder engagement events, particularly with PCNs and GP practices, particularly within Portsmouth. We had a very good session in February for a whole Friday morning where lots of feedback was given to the team. And then part of that was to actually baseline where we are with the digital offerings that we currently have across primary care and across our Hampshire and Isle of Wight setting. In essence, the roadmap has got 4 major projects. It's the first is digital access and self-care. So as already said, online video consultations, NHS apps, self-management, remote monitoring, practice websites. We then have a second one, which is collaborative but working. This is more pertinent to our other CCG colleagues, PCN GP practices. This is looking at potentially having a primary and a community care integrated record. But as you know, across the city, we're all on System 1, so we're sort of ahead of the game on that respect. One of the third work stream is digitalisation and optimisation. So that would include population health management, and an interesting one for our GP practice colleagues is digitising Lloyd George notes, so it's getting rid of all the paper notes and looking at that. And as previously mentioned, the digital telephony. And the last but no least, and this is what I've been focusing on, particularly across the Hampshire and Isle of Wight footprint within my role, is the infrastructure. And that was HSC, so that's the N3 replacement, so HSCN, as well as the new Office 365 and new ways of remote working and mobile working. So they're the four key themes that we're going to look at in terms of the roadmap. In terms of delivery at the moment, there's lots of work going on in terms of agreeing to this roadmap. I know colleagues across the partnership are actually taking this paper to their exec committee today, and we are just waiting for confirmation of funding, which should be imminent on that, but it has been slightly delayed because of COVID, etc. We do have an end game to get all of those 4 work streams hopefully complete by June 21, but until confirmation of funding is confirmed, that might slip. And yeah, so I can take any questions now. Or Chris, did you want to do your update?
I think we've got a couple. I think Nick and Terry have both got their hands up, so I don't know whether they want to ask their questions first.
Yeah.
Yes, please. I just one comment and one question, if I may. Comment around telephony. I think it's really, really vital. What we know is that, particularly as practices have had to put a lot of activity onto the phones, so telephone consultations in place of what previously might have been patients walking through the door and asking questions, or face-to-face appointments, has meant that the kind of number of phone lines is really being stretched, and it's quite difficult for practices to do anything different. So it's great that telephony is in there. I think also in terms of collaborative working, we really need to understand how telephony systems link to enable some of that collaborative working across PCN. So again, brilliant that that's part of it. My question is around money and predominantly around Lloyd George, actually, because when we've looked at this locally, we think it's going to be a really, really, really expensive exercise. So have they given any indication, Jason, that they know how much it might cost to do some of that? Because it's a real priority, and if we could do it, we would free up space.
We would. In terms of the digital, so all of you may or may not know, this year's GPIT capital allocation is 2 million, and that just covers the BAU. We have been given allocation to fund Office 365, so we got just under 1.3 million for that. And particularly for the digital first, we are being, as I said, we're doing a 4-year profile, hence the creation of the roadmap for funding. We are expecting 2.1 million this year to help kickstart those programs, and we currently, out of that, have had confirmed we've got 1.4 million to start. So we are getting money. It's not as much as we expected, but we can start doing something. I think what we also have to remember with the investment we've put in with HSCN, because we've put in much bigger connections, there may be an opportunity to explore how we can sweat those assets in terms of looking at doing other things with telephony as well. But we really are just starting at the beginning with telephony, because as some of you know, some practices have signed very long-term contracts with current providers, and what ramifications that might have. So yeah, it's real just a start, just to start off a 10 at the moment to see what is out there.
Thank you. Okay, Margaret, we've got Dr. Moore.
Yeah, so this is very timely, obviously, because GPs have massively transformed how things are going in terms of access and total triage, etc. Just a couple of questions in relation to the local stuff. Obviously, as Jason you said, we use System 1, and currently we're using a sort of bolt-on bit of software called AccuRx. Is there any update on where we are with a kind of solution to that on the longer term? Because I think videos have been quite popular. Obviously, the bolt-on bit of software. That's the best. And the other question was with the Lloyd George. Will that be something, obviously, to the benefit just of the practice, so that we can see the records of stuff? It won't. It's not going to be available to the patients to see, because at the moment patients can't see all of their attachments, documents, letters, etc. on their remote login or the NHS app.
Yeah. Now, whether that might change regionally or nationally, I don't know, but not currently.
Okay.
We do know, and I'm trying to lobby TPP, because we do know EMIS, and this is an update for Terry as well. EMIS offer the complete solution of digitisation in terms of scanning and attaching to each record, which we know the scanning bit and putting it into a digital format is very easy. The hard bit for practices is then going into each individual record to attach that copy of the Lloyd George, because it's really time consuming. So, you know, if we do the maths very quickly, it's probably about 3 or 4 or 5 minutes to do, you know, and we worked out it'd probably take an admin person the best part of a year to do an average size practice if every patient had a Lloyd George note to summarize.
Yeah.
So that's where the real cost comes into it. But EMIS are offering now that service end to end, and I'm hoping TPP will do the same. So, you know, they do everything essentially, and they can do a lot of automation. Something we could piggyback off PHU with their robotic automation, because it's something that could be done quite straightforward. But yeah, I'll stop my blue sky thinking.
And what about the video consultation?
So remote. We are taking that to the user group today, actually, for a bit of discussion, because the AccuRx solution as of April is going to be locally funded. So we need to have that bigger conversation about what do we do about that, and also bear in mind the AirMid and the System 1 application, which is embedded, is free. So, but the trouble is, because of time, we haven't had practices at the moment to try that yet at the moment. So we're hoping at the user group, Chris can encourage some practices to pilot the AirMid or the System 1. You don't actually need AirMid with the System 1, because you can just do it within System 1, because you'll be able to text or email that link to your patient. And then
I think people picked up pretty quickly what they were doing before, so I wouldn't envisage there being a huge problem with uptake. Again, if we needed to change to something different, I think what we have shown with all of this is that people can be quite agile when they need to, and adopt some of these things quite quickly. And I think that's been a real positive that's come out of all of this.
Yeah, here. You know, it's been amazing in terms of, you think the kit we've rolled out and the way you've changed your practice in terms of how you interact with patients is great. So I'll shut up now and let Chris.
Thank you.
We do have Jackie Powell's hand up, and we do have Mark Compton.
Jackie?
Okay. Can you hear me okay?
Yes, yeah.
Okay. I had a couple of really basic ones, and especially when it comes up to writing these minutes up for the public, things like, I didn't know what George Lord notes are, and I don't necessarily understand some of the acronyms. So could you just tell me what George Lord notes are? So
essentially, it's the old written note. So the Lloyd George is basically the envelope. So where written notes, handwritten notes would go in. So practices still have quite a few of those within their premises.
Oh, I see. So it's quite a big undertaking, and what you're telling us is that potentially TPP could do that.
Yes.
And capture all of that. Thank you. Yeah. And HSCN.
So that's the health. Sorry, no, my fault. So that's the Health and Social Care Network. That's replaced what we call the National 3, the NHS network. So this is a secure. Well, this is a new network, essentially, which is quicker and bigger in terms of capacity, and it also means that social care partners also will have a HSCN connection, and how we'll link everything up.
That's great, thank you. And then literally just a couple of quick ones. How extensive is use of the NHS app? Is that a growing success, and is it being helpful? And when we're looking at the PCNs, I wondered if also, is that something would it make sense to do that across the city or via PCNs? That's my question.
Yeah, I think the NHS app is increasing in popularity, but you know, I say that this morning, but the new we have another app that obviously the track and trace has just been launched this morning as well. So there are a plethora of applications, but they are being used. Sorry, Jackie, what was your last point?
I just wondered, with that, what you've just said, is the take-up of the NHS where you'd want it to be on the NHS app or not? Or are we hoping that people go with track and trace and then come back to the NHS app later?
Well, ideally, you know, the more people use it, the better it will be, because then the idea of the NHS app should be like the default place to go for you to access all the services, if that makes sense. But unfortunately, I don't have the current figures. Perhaps I can get some figures in next meeting or so. We'll have a quick look at that of uptake, because me and Chris regularly sort of send out figures for how we're doing for online consultations, video consultations, that sort of thing. So perhaps we can do a little report next time for useful.
That would be very helpful.
Yeah,
for me, if it is for everybody else. And then I was going to ask about, you know, what I did ask was about PCNs and whether actually a citywide approach might be more beneficial for Portsmouth, or actually maybe PCNs. I don't know where the thinking is, or whether that's been considered.
Yeah. I must admit, the last stakeholder engagement within the city, all PCNs were present at that, and that sort of helped us, you know, gather their requirements and ask, so to speak. But also, what we don't want to do is stifle any other PCNs that want to do potentially do something different in terms of how they want to be sort of innovative and potentially try new applications or bits of software. So we're trying to encourage sort of a holistic approach, should I say, in terms of try new things of technology. So
okay, thank you. Sorry, I've taken up enough time. Thank you.
Okay.
Thank you. There's 2 points I just wanted to bring up. So thank you, Jason, for going through that. The first point was it ties into one of Jackie's comments, actually. You know, it's just about the digital access. I was just reflecting on the fact that obviously we are improving and digital access to services. I just wonder whether we could do more to encourage its uptake, to promote it. I think there's an element of that around primary care, especially because of the total triage approach. Phone lines are becoming even busier, even more difficult to get through. So I think it would really help patients if they're aware of some of these online consultations even more. That would help with access. And it's not just primary care as well. So I'm thinking 111, for example, and encouraging patients to use 111 online. And that kind of thing. I wonder whether there's a very large kind of comms and engagement campaign we can do with the public to actually help them to access healthcare services more easily.
Yeah, I'm hoping there's going to be a new campaign, national campaign in highlighting this. But I think we were fortunate, particularly across Hampshire and Isle of Wight, because we went out and procured an online consultation solution 3 years ago. So we were quite lucky in that respect, and we've embedded that. But other areas haven't been so, if that makes sense. So it's quite difficult. But I take your point, and it's something I'll take back to the regional team to say, you know, if anything, could we have a regional campaign? Yeah, that's definitely something I'll raise with those guys, and raise at the ICS and STP as well.
Thanks. And then just a second point, I know this is predominantly a kind of primary care roadmap, but I just wanted to ask about work that was being undertaken in terms of further integrating primary and secondary care IT, and is there a lot of work going on around that, or is it again one of those things which is very difficult?
Yeah, I think for us as the city, we are very, very fortunate to have our community mental health provider on System 1 and adult social care on System 1. So we are very, very lucky. And our default response in terms particularly for secondary care is, if it's not within your local business system, then you would use CHI. Now, I know people swallow and sigh when I say those 4 letters. However, we are waiting for the new provider of CHI to be operational. Unfortunately, that was meant to be this month, but it's been delayed because they can't get the one of the primary care feeds to work in real time. But as soon as that's cracked, the Orion product that we are getting in terms of what it looks like compared to the current offering is completely different. And hopefully we'll be able to encourage our primary care colleagues to potentially use it a bit more because it is a bit more user friendly. And that's the way at the moment. But there are many ongoing conversations about that. But unfortunately, we are very much tied to system suppliers and how they cooperate and work with one another. And what you have to bear in mind, the more and more they open up their systems, the more and more they've sort of potentially people could then say, well, isn't it easier just if we all go to one system and things like that? So, yeah.
Okay, thank you.
We got Terry Russell's hand up.
Yeah, I was just going to give some feedback on Mark's first point, actually, about raising the profile of online. It's certainly something practices have been encouraged to do, so to utilise all kind of forums or media to get that message out there. So websites should be directing patients to use online. Also, they've been using social media, so they've been much more hot on kind of sharing information via social media and on answer phones. So if patients are phoning up and being held in a queue, to advise them that they could use the kind of e-consult as an alternative if they don't have an urgent problem and it's something that they could put via that channel. So they are doing quite a bit. And just to say, this week there was an article in the news, and we know nationally there was a bit of publicity around providing face-to-face appointments, and Chris will come on no doubt to talk about activity. But we used that as an opportunity as well to explain that the delivery of primary care has changed radically. And whilst we all want to get back to some kind of normal when we finally get through this kind of pandemic, it will still absolutely utilise some of those other channels. So it will still absolutely utilise e-consult because it's a really effective and efficient way of managing some patient conditions. Equally, telephone triage is convenient for patients and is appropriate in a number of cases. So we will continue with what is a radically overhauled model of primary care, actually. But we'll use that kind of query from the news about we've heard nationally practices aren't offering face-to-face to say, actually, yes, they are. But in addition to that, look at what practices have been able to offer around telephone consultations and using online. So we are doing it locally, but absolutely anything we can feed up to say a national campaign would be brilliant is a good shout.
Okay. Roger Batterbury.
Yeah, thank you. I think we mustn't miss the patient voice in this because lots of conversation about digitisation, and I'm just wary. I've seen quite a bit of research. King's Fund, Healthwatch England have done work, the Dr. Zoom project, about sort of digital inequality where people don't have access to sort of Wi-Fi, laptops, privacy to make the call. So I think don't want to lose the patient voice. And something about the user group that I think you mentioned, Jason, and just wanting to make sure perhaps there's a patient voice that can go into that somehow.
Yeah, definitely.
So just wanted to sort of make the point. And Mark stole my other point, which was the bit about secondary care, because obviously Portsmouth Hospitals Trust have multiple systems, probably one per department. Very frustrating for patients.
it is, Roger. I acknowledge that, but PHU have made huge progress. They have a system now called Minestrone. Read into that what you will by that name of that solution, but it gives one view of all of their information, of all their systems about being patient centric. So they are making real good strides in trying to rationalise their systems within that organisation.
I've not heard of minestrone, but thank you very much. I'm feeling hungry.
We've got Dr. Moore.
Yeah, sorry, just a quick thing, just to pick up on what Roger's saying. I mean, I think feedback we've had, obviously, we do need to make sure we don't lose sight of the patients, because obviously they're having to navigate different ways of doing this. Feedback we tend to have, again, this is informally, I haven't done a consultation as such, is that people do tend to quite like it. I think we've got to be mindful that we make sure that we use the things that patients can actually access. So most people have got a phone, and so we can use, so quite often, but some of our patients will not want to do a video consultation, and so those are the ones where we need to use the phone, make sure that we see them, sometimes go and visit them if necessary. So I think it is about appreciating that this is there's a menu of stuff, and that people get the right thing for them, and we don't it isn't one size fits all.
Absolutely.
Okay, any other comments or questions, or shall we move to Chris?
Yep. So I'll just give a quick overview of where we're at with some of our digital sort of technologies across the city, what's been taking place, especially since the pandemic. So we're talking sort of early March. As Jason mentioned, HFCN, so this is a replacement for the N3 connection, so around sort of better and quicker connectivity to the network. We've had 100% implementation across the whole city, so we've done that, so we've met that deadline, which was the end of August. N365, so Office 365. So at the moment, we're rolling out more on a corporate level. So, for example, across the CCG, and then over the next year, this will be rolled out to all of our practices as well. So this is a big program of work. Laptops, so we're talking from early March up until now, and we've issued 111 laptops across the city. Webcams, again, from early March, webcams and headsets. So webcams, we've issued 236 to our practices, and headsets, we've issued 132 as well to all of our practices. Video consultation, so again, as mentioned, this has been quite, at the very, very beginning of the year, we weren't really utilising video consultations whatsoever. So practices have been fantastic in adopting this new process. All of our practices are with AccuRx, but as Dr. Moore said, I think we need to review this and maybe look at other alternatives going forward. But all of our practices have been using this product. From March, there was utilisation was at 331 video consultations for that month. And then in May, there was a huge increase, so about 300% increase in utilisation at 1,330. But our latest figures for August, we have seen a decrease, so a decrease of about 76%. So we're now at about 314 monthly for our monthly utilisation. This figure seems to be flattening out now as well, so at around the 300 mark, we're seeing that usage. Online consultations, so we use eConsult for that. We've been seeing quite an increase in utilisation since early March. Month on month, this has been increasing. So March, it was at 3,839 online consultations submitted by patients. And we've had our sort of largest utilisation for the month of August at 9,002. So we've seen 134% increase in the utilisation of that. Okay, has anybody, that's just a quick overview, so has anybody got any questions or anything? No? Okay, thank you.
You're muted, Margaret.
Margaret, you're muted.
can we move back then to the risk register and note the progress on the digital primary care work? Thank you.
Yeah, I wasn't necessarily going to draw anyone's attention to anything specific on the risk register. I would love to have been able to say that we could stand down some of our COVID risks, but we obviously know that isn't the case. What I would say for general practice and actually across the health system, we know that things are potentially going to be quite tricky as we head through winter. And what we're also trying to do is maintain a level of kind of routine and normal activity in that. So I think increasingly our services, our providers are going to come under pressure and it's going to be quite difficult to maintain. So we're absolutely exploiting the opportunities of getting together in primary care networks to talk about solutions, you know, making sure business continuity plans are really robust, and having some kind of escalation process so we know what the steps are and what the triggers might be to set those off. So, you know, understanding the implications of a local or national lockdown, etc., etc. The only thing I would say is we're obviously always mindful of what nationally NHSE are telling us around the GP contract. So we've very much worked in a kind of a command and control process. So nationally, changes have been made to the contract and standard operating procedures have been published for general practice with a view to getting consistency, and that has been really, really important. And certainly that's the messaging we need to get out to the public. Come back to the point about the news article this week. Practices have been following the guidance. They've been making sure that they are following infection prevention control measures, keeping patients safe, keeping staff safe, as well as delivering services. So, you know, they're absolutely following what they've been asked to do nationally. So, like I say, no real change to those risks, but absolutely we'll need to keep on top of any mitigating actions we might need to take.
Are there any questions or comments on that? No hands up. Can we just then note the risk register?
Hi, Margaret. We've
Jackie's
got
got her hand up.
Cal.
Okay. Jackie?
Oh, yeah, sorry, I was slow to get my hand up. It's not a direct risk, I think, that can be articulated within this risk register report, but I am cognizant that, of course, the primary care team that we have provide an enormous amount of support to practices. And if we're losing our deputy director, do we still have that capacity, who's been brilliant, do we still have that capacity to provide the support we would like to primary care? That's the question.
Thank you, Jackie. Joe, I don't know, do you want to, are you on the call? Do you want to respond to that one? I know Simon had been endeavouring to join, but hadn't been able to. But Joe, are you happy to take that one?
Sorry, I'm struggling to hear. Are you able just to repeat that question, Terry?
Yeah, Jackie, go on, you go.
I was going to say, because of the enormous amount of support that the primary care team gives to primary care, of course we're going to be missing our deputy director, who is Terry, and what were the plans to replace her or model the primary care team so it has the sufficient capacity to support primary care in the way we like and do?
Yeah, of course. Apologies that my connection isn't great and I'm struggling. Can you hear me?
Not very well. You're very faint.
Okay, I will try and shout. Apologies. Yeah, so what we are looking to do is an interim, because I think we recognise that we need, you know, as we've discussed today already, primary care is changing quite dramatically, and the way services are delivering is changing. So we need to think about how we can support primary care both at a PCN level, but also continue to do so at individual practice level. So Simon Cooper has just recently has been on a part-time secondment to the CCG, to the National Pharmaceutical Team, which has just recently finished. So he's coming back to the CCG full time. So as an interim arrangement, Simon will pick up the management of primary care for the CCG and the team, and that will provide us an opportunity to really think through what we need and how we can increase our capacity to support practices in the way that they, and PCNs in the way that they need us to, and also to think about how we can perhaps get smarter at some of the business as usual type commissioning and contracting approaches, so that we can really help and create capacity within the team to manage the transformation developments that that all of the team want to do. So that's our interim plan, and I think Simon will be able to really work closely with the team, with practices, and manage the links across with pharmacies as well, which will be important as we go through as we develop PCNs more.
Okay.
Can I just also come in on that just very quickly, just in response? I think we also discussed yesterday with Chris Horan about some of the sequencing and the commissioning meetings and some of this practice support and the way that we check in with practices, and we're looking at that at the moment in checking in with practice managers to see what that programme will look like, because we've had a programme of sort of practice visits and quality visits, etc., and we're trying to make sure that we consolidate that, make sure that there's good support and good links, so that people are feeling, the practices are feeling supported by the CCG and their buddy people sort of over the coming months. So that's also a little bit of a work in progress to make sure that we're offering something that may be slightly different from what we've done in the past as well, in the light of COVID and how we have to then do a lot more stuff remotely.
Thank you. Any other comments on that? Okay. Can we then move, Terry, can we move to the estates update?
Yeah, certainly. Sylvia's prepared an update for you. I won't go through all of the sections because it is presented in a way that you can obviously read what's there, and most of it's relatively straightforward. What I would like to discuss, and there is an action for Primary Care Commissioning Committee, is our premises improvement grants for both this financial year and next financial year. And just to give you a bit of background, we sort of every year have a round of bidding, if you like, for capital funds that we can use as minor improvement grants. So they were never intended to be the kind of big scale redevelopments or new builds or whatever it might be, but we're certainly there to help with improvements in general practice. Now, increasingly over the last few years, practices have been encouraged to think about things that aren't what traditionally we would get, which is requests for new flooring or those kinds of things, but actually to think more about how we bring into use additional space within the practice, how we might develop the practice estate so that it's better able to manage kind of patients coming through the door. So it gives consideration to people who might have less mobility or all of those kinds of issues really. So we were asked by NHS England to prepare our bids for this year, which we did do. And then obviously we had COVID-19, and there were various other calls on a lot of those capital pots. So you've heard how many webcams, headsets, laptops have been distributed up and down the country, actually, not just for Portsmouth. So we are not entirely clear, and Nikki's not on the call, but Nikki has done her best to get a definitive answer from Region and from NHSE about whether we are going to have any funds available for practices this year, because we actually believed we had some really good schemes and some really necessary schemes to take forward. But as I say, we haven't actually had any clarity about whether that money will be made available to us. So as a team, we have sat down with our finance colleagues to really prioritise those bids and the asks for funding this year. And we believe there are 3 schemes that we would want to take forward and potentially then go at risk that we don't actually get any reimbursement from NHSE for putting those schemes in place. So the three schemes we think we need to take forward are Kirkland's, and this is actually about refurbishing and repurposing their garage to give them additional space, which is really vital. They're one of the few practices in the city that's actually seen their list increase quite substantially, actually, over the last couple of years, and they're actually really desperate for that space. We have talked to them about alternatives, so very much encourage them to look at what they could do across their primary care network, and they are exploring that. But we believe this is actually space that the practice themselves need, in addition to some of those other options they might have within the network. Equally, that's the case for Trafalgar, where it's actually repurposing and refurbishing rooms to give them additional space that they need, both for the practice and potentially for PCN activities. And then the final one is around Portsdown practice. And this is actually, you'll all be very aware, Portsdown merged with Hanway, and the Hanway buildings are closing. And initially there was a bid actually to extend the Kingston Crescent site for Portsdown. The work that they've done, and I've been out to see that the work that they've done, as we've kind of been through this pandemic has really escalated around kind of bringing teams together, utilizing their space really effectively, and working remotely as best they can. So the space they require is certainly not as extensive as we thought it previously was, but they will need to repurpose some space, certainly at Kingston Crescent, in order to fully accommodate all of the staff and their new model of service within that building. So those are the three schemes that we think are really vital this year. We do have other schemes that we would have wanted to include, but we believe those could kind of stretch out into next year if we do get any funds. So those projects are approximately 135,000, and that's what we would like the committee to approve. Like I say, we are still hoping we get some money, but we're not clear on whether that will be the case as yet. Nick's got his hand up, Margaret.
Okay.
Just a quick question. Obviously, there's the other ones apart from the one that you were just referring to are all for obviously for additional clinical space, and obviously if these are going at risk that the CCG's having to fund on the basis of not being guaranteed of reimbursement for this, are we happy that the other one is so essential that it needs to be done? Because obviously that one is more of a logistical thing, and obviously in the merger that's obviously something that they need to have worked through. Obviously may well be part of their plan. If we're prioritising patient focused stuff, the actual clinical space, is that something that maybe we need to just be mindful of? That was all.
Terry, it's Michelle here. Would it be helpful if I just say where we are in terms of the CCG capital process?
Yes, please.
Because we do that as a set of CCGs. So all the CCGs within Hampshire and Isle of Wight, we've been doing that for a number of years, actually since our instigation. So as we have expressed, because of COVID-19, some of our capital allocation has been diverted into getting laptops, etc. So you could argue some of it would have formed part of business as usual. We are, as a set of CCGs, still trying to pursue additional capital allocation linked to that COVID response. In the meantime, what we've been doing is looking at our programmes of work, including the minor improvement grants, as Terry's just said, to see what we could slip into future years. So it's, all the schemes that Terry's mentioned, we've reviewed. We're looking at maybe like a 2-year programme so that we've got things off the shelf for when we do get offered any further allocation. So we are about of a allocation of about 3 million across the patch, about £140,000 adrift now with our plan. So we think we are virtually there with plans, and that NHSE will give us the green light to go ahead and go through all the process. So in terms of the 118k that Terry's just mentioned, it is more likely now that we will receive an allocation that will cover that expenditure. So I wouldn't be asking Terry to come and ask this committee to go ahead at risk if I thought it was a significant risk. And for that sort of level of funding, I'm sure we'll be able to ensure that the CCG is not doesn't have any disbenefit as a result of that, given how big we are in comparison to £100,000 expenditure. And we need to make sure that we continue our improvements, don't we, in our properties, and make sure that they're fit for purpose. So if that's helpful.
Very, very helpful. Thank you, Michelle.
Any other comments or questions? Any other hands up? No. We are then asked to agree and note this. Can we do that?
Yeah, I'm happy.
Right. Can I take silence as agreement? Thank you.
Yeah, agreed.
Okay, thank you.
Agreed.
Good. Thank you. Can we then move to policy outcome framework? Steve.
Thanks, Margaret. Apologies, I've just noticed on the front sheet it mentions about committee members noting a report, but of course there is no report. This is a verbal update, so apologies for that. But what I can do is provide Lisa a bit of a summary of what I'm going to talk about today, so that she's got something for the minutes to share, if that's helpful. But yeah, an update on the QOF this year. So I'm sure you know that QOF is a voluntary scheme. Or it is in theory, but actually in reality, all practices sign up to it because it's obviously worth a lot of money. So all practices sign up to this every year, and it rewards practices for achieving certain clinical indicators around things like asthma, diabetes, COPD, etc. There were some improvements made to the QOF for this year, in line with the findings from a review of the QOF back in 2018, and that was to bring some of the clinical areas in line with the latest best clinical practice, particularly relating to asthma, COPD and heart failure. And there were some other minor changes made as well. But the main changes I wanted to highlight today really is in light of COVID-19. So to support practices in their response to COVID and that need to really target the most vulnerable patients, there are a number of changes agreed for this year. And it's partly to help practices reprioritise aspects of care, partly around looking after those patients with long-term conditions, particularly, clearly a very vulnerable group, but also it was around guaranteeing some income protection for practices as well for this year. So the majority of indicators in QOF are actually subject to income protection. The practices have been asked to still make efforts to deliver against those indicators, and we can still monitor that to see how that goes. But essentially, practices have been asked to prioritise the care that they feel is necessary and feasible to deliver. The guidance clearly says that can be done by the phone or virtually through video, but also through face-to-face consultations. So, for example, I've got a chronic disease review next week with my practice nurse, and it's perfectly reasonable to do that over the telephone. And that's what we're doing next week. There'll be other patients that obviously will need to be seen face-to-face for their QOF reviews. And contrary to what you sometimes have heard in the media, we touched on this earlier, practices are seeing patients face-to-face for lots of different things, and that will continue where necessary for the QOF. But to be eligible for that income protection, there is a bit of a process that we have to consider. So practices do need to agree with us, the CCG, how they're going to identify and prioritise the highest risk patients. So that could be patients from BAME groups, those in deprived areas, and perhaps those that have got a history of missing their QOF reviews. So really being proactive around those high-risk patients. And we'll be working with practices over the next couple of months just to sort of finalise some of that. There are some QOF indicators that are still going to be based around achievements, so not protected. That relates to flu indicators. So there are patients with diseases such as CHD, diabetes. There are points on offer for undertaking the flu vaccinations. So they put a real emphasis on that. That won't be protected this year for obvious reasons. And they've actually doubled the number of points available for that. So they put a real emphasis, obviously, on the flu programme this year. They've also put quite a large emphasis on cervical screening. So they've doubled the points attached to that. That's around practices proactively following up on those patients that had their appointments delayed or cancelled previously due to COVID. Also, the disease registers are not covered by income protection. Clearly, if patients are not on the disease registers, they're not going to be getting their necessary reviews. So it's recognised that that element of case finding, getting people on the registers is really important. And then finally, there are a number of indicators which relate to those with the long-term conditions, particularly around optimising their medications. And again, that will be subject to achievement of the necessary indicators. The other big change was around the quality improvement domain within QOF, and they've scaled that down a little bit and provided some real focus. So the two focus areas to be looked at are learning disabilities and early cancer diagnosis. So this is in order to try and support and contribute to the restoration of those services. We've already done a lot of work around learning disabilities, but in view of that being within the QOF domain this year, we've got a meeting set up for the next couple of weeks to just look at how we can support practices achieving some of that, and also what assurances we might need in place in order that we can actually sign off on the QOF at year end. So I'm meeting with Nick Moore and the learning disabilities lead nurse at Solent in the next couple of weeks. And on early cancer diagnosis, we're also meeting next week with the relevant commissioners to go through how that, how we can support practices achieving that and increasing the screening uptake. Okay. So the plan is that from next year, QOF will be reintroduced in full. So the income protection only is relevant for this year, but of course that may be subject to change. And any further changes over QOF will be resolved through the usual contract negotiations over the coming months. So from the CCG side, we'll keep a close watch on all the QOF indicators before we sign anything off, including the ones where it's there's an element of income protection, just to see what impact that has made. Happy to take any questions or any additional comments from any of my primary care colleagues.
Terry's got a hand up.
Yeah, I have got a comment. I just wanted to say and provide some reassurance really to the committee. So you will all be aware, and Nick alluded to it earlier, we have a CQIN, a Commissioning for Quality and Innovation scheme with our practices. And what we found in previous years, and certainly has run true this year, is that we tend to kind of preempt issues that might come out nationally or where we might need practices to focus additionally. So within our CQIN, we already had quite a bit of work around learning disabilities and increasing health techs over and above what was expected nationally, and also some focus around screening, although not necessarily some of the activities that they'd want us to do around early cancer diagnosis. So what we are doing, and this is where I do need to reassure the committee, is we're going back to our scheme to make sure we're not double paying for some of those activities, but that we're giving additional support and being really clear with practices about what they should be focusing in on. But we are mindful we don't want to start something new either, because I think, as I said when we were talking about the risks, there is a real risk that practices are going to start to feel the strain, and I think they already are, because of increasing demand and also some of the kind of constraints because of staff having to self-isolate, etc., etc. So we will review what we've got within our scheme, and we will do our best to ensure that we're supporting some of the national focus and some of those really important areas around people who've been particularly vulnerable, picking up on Roger's point earlier about some of the inequalities that have been driven by kind of this use of technology, focusing in on some of those areas that will really make a difference over the next few months. But yeah, we often find we put in place a scheme and then something comes out nationally to tell us we should be doing it. So that's a good thing. That's a good thing.
Any other comments? Hands up. You're going to provide a summary of this, Steve, for Lisa, so that we can have a written copy of that. Okay, thank you. So if we could just note that at this stage, thank you. And then move to the flu programme. Steve, I think that's your then.
Yeah, just to give a bit of a brief update on the flu programme for this year. Obviously, even greater significance this year than previous years. So in terms of patients that are eligible, just as a reminder, it's patients that are aged over 65, those that are under 65 but in a clinical risk group. Then we have all pregnant women, children aged 2 to 11, and I think it's the 11-year-olds that are the new cohort, so those in year 7. We've got patients in care homes, and then a couple of new ones. We've got household contacts of those that are on the shielded list, or household contacts of those that are immunocompromised. And then finally, it's the patients that are aged 50 to 64 years, but no clinical risk group. However, those patients would only be eligible if and when the other groups have all been vaccinated. So further information to come on that later in the programme. But there's been a real emphasis put on those that are in deprived areas and those from the BAME communities as well. So practice has been asked to really focus and prioritise on them as well. The targets have increased, so pretty much across the board, we're looking at 75% target for this year, whereas previously that only applied for the over 65s, and it was 55% target for the other groups. So a real jump in the target for practice to try and work towards. Just as a reminder of our achievement from last year, we were just below that 75% target last year at 73.6. So close, but not quite close enough. So a bit of work to do there. And for the other groups, there's a much bigger gap. So for the at-risk patients last year, we were at 47%. So you can see that the increase needed there is quite significant. Pregnant women was around the 40% mark. And the 2 and 3-year-olds, which are the ones the practice do, they were at 53%. So yeah, a lot of work needed to try and get more patients in. But obviously we're hoping and anticipating that more patients will come forward this year than usual. But we are liaising with practices, especially those with the biggest gap, just to check in with them and what plans they've got for trying to make these improvements. We've heard from some practices that they're doing not drive-throughs, but walk-throughs, if you like. They've got tents up outside the building and having people walk through without having to go into the building. And apparently that's been working really well, partly because of the good weather we've had, up until the last couple of days anyway. We know practices are using Church Hall in some couple of cases, and we also know that practices are trying to expand the workforce as well, trying to put extra resources into this year's campaign, so getting more healthcare assistants, for example, to deliver the flu jabs. We will obviously keep a really close watch on how the uptake is going over the campaign. We get weekly data, which we will keep a track on, and it may well be that some further collaboration is required with other providers to ensure we work towards those targets. So practice is very much happy to crack on and try and get as many people vaccinated as they can, but we're constantly looking at how we can work more closely with pharmacy, community nursing and the hospital as well. So currently the hospital are doing the maternity patients and also the at-risk patients if they've got an inpatient or an outpatient appointment. So that's in place to support practices. Community pharmacy will also obviously do some patients as well, as they have done in previous years. And we will link up closely with community nursing if and when we feel that there's a need to kind of involve them a bit more. But we know that they're under a lot of pressure at the moment as well. So for now, practices are doing the housebound patients, for example, themselves. One of the main issues that practices are worried about is the stock availability. When they put their orders in, it obviously wasn't to try and achieve 75%, so it was based on previous targets. but we know that there is a central stock that should be available, I think, around end of September. We wait to see how we can access that, but certainly one of the main worries is how practices are going to access the right amount of stock in order to work towards those targets. So that's something that we're keeping an eye on, and hopefully we'll have some news around that central stock shortly. So we're having lots of different flu working groups at the moment, working through some of the issues, both locally and Hampshire-wide. Terry's quite involved as well, so again, very happy if Terry, you want to add anything else to what I've said. Otherwise, happy to take any questions.
We've got Joe York.
Joe?
Sorry, I've managed to log in now, so you might be able to hear me log in properly via the laptop. Terry, did you want to add anything? I was just going to add about how we're linking in with partners in Portsmouth, South East Hampshire and Hampshire and the Isle of Wight, but I didn't know if you wanted to say anything first, Terry.
Just on stock specifically, I think stock and workforce are the two biggest risks that we've got to our flu programme this year. So Steve mentioned end of September. End of September is actually for the guidance of how practices will access additional stock. The latest we had was that stock would not be available until November, and we have fed up nationally that's not going to enable us to meet the requirements within the programme this year. November is too late for us to vaccinate the whole population up to 75% within those cohorts. So we have fed that back rather strongly, both via public health, because obviously they are the commissioners of this service, but also through our regional team. So we are aware that that's a big risk. And again, workforce is going to be a risk in terms of the issues around staff having to self-isolate. Have we got enough training? The LMC has been extremely supportive, as has Julia, who unfortunately isn't on the call today, to make sure that we have got staff appropriately trained and able to deliver. So less of an issue, I would say, than stock, but obviously still a concern that we will monitor. And as Steve says, we have got the option of calling in support from elsewhere if necessary as the programme progresses.
Okay.
Yeah, and it was just to add to that, really, just around how we are linking in, and we'll continue to link in with Hampshire and the Isle of Wight, and we've also got a Portsmouth and South East Hampshire flu group as well, so we can work with our system partners, particularly as if and when we get concerns around the stock and the workforce, and working with community partners, and also in supporting practices with comms. So Hampshire and Isle of Wight have produced a communication pack for practices to use, which has gone out because, again, some of the national communications are just starting to come up but weren't due to happen in October. So we've been doing quite a lot locally as well around that.
Okay. Any other questions or comments? Any other hands up? Can we just note the progress on the flu programme then, and how that's being monitored? Thank you. Can I just ask a question? I've been away for 2 weeks, so I'm a bit behind the curve. But Jackie's question was about losing our deputy director. Is that so, Terry? Does that mean that this is your last committee input?
Yes, it does, unfortunately, Margaret. And my apologies if you weren't aware. So I have been offered and accepted the role as the new programme director for our now known as Portsmouth Provider Partnership. So that's the old MCP, as you would know. I am not leaving Portsmouth. I am absolutely committed, and I will still be around, but I will be leaving my role in primary care. And as Joe said, Simon will be taking over as a kind of director of primary care. So much more the traditional model of what we were used to in Portsmouth, someone who's got that medicines optimisation and general practice oversight. So yes, it is with great reluctance actually, but also excitement, because I think there's lots of opportunity within my new role too, but I shall certainly miss working with practices and yourselves.
Well, congratulations and best wishes for the new role, but also a lot of thanks for all the support you've given to the committee over the last few years. Thank you very much. And we'd just like to record that.
Thank you.
Okay. Can we then, our next meeting is in public is on the Thursday, the 26th of November 2020 at 9:30 p.m. If there's no other business, no other questions, I call the meeting to a close. Thank you. Thank you for your attendance.
Thank you.
Thanks.
Thanks, everyone.
Thank you. See you in half an hour.